Hello and welcome back to Best of the Day from the 2013 ASCO Gastrointestinal Cancer Symposium, the 10th anniversary gathering of this group. So it's been a really interesting meeting. Things have pretty much shut down on this final day, the colorectal day at the ASCO GI meeting. And we're joined this afternoon by Dr. Axel Grothe from the Mayo Clinic. Axel is one of our regulars and always very dependable to bring us up to date on what's going on and to give us the clinician's perspective. So, Axel, once again, to Best of the Day, thanks so much for being here.
Thanks for having me. Actually, I was listed on one of those, the ASCO posts about I'm a sustaining member. It's my 10th time.
You and John Marshall both.
Marshall, Alan Vanook. Yeah, it's kind of interesting to see also what happened the last 10 years. I mean, this meeting started out very small in Florida, the West End, in Hollywood, Florida.
Right, and they had been alternating for a while, but now it's pretty much San Francisco.
That time, 10 years ago, was bevacizumab, came to the market, and it was actually before it actually came. It was 2003, yeah.
Okay, so tell us about this Italian trial, FOLFOXIRI-Bev versus standard FOLFIRI-Bev.
So the Italians have a lot of experience with FOLFOXIRI, and the idea was to see whether the addition of bevacizumab can improve response rate, can improve progression-free survival, which was the primary endpoint of the study, and what is the toxicity profile. I think we've gotten a little bit gun-shy about kind of combining too many agents in a frontline therapy, but they show that the PFS parameter and response rate were actually improved quite significantly. They don't have data on overall survival. They didn't present data on overall survival. So the question of whether this is a strategy that will eventually benefit patients with long-term survival is still out there. But they had decent progression-free survival benefit with a decent hazard ratio and a response improvement to push this regimen reliably into the 60% response range. Right. So I think this is something which could be considered for patients, number one, where we need a response. We've talked about, for instance, liver-limited disease in patients perhaps with KRAS mutant tumors where EGF receptor antibodies would not be appropriate to be used, or patients who have a very bad biology. There's actually the same group presented data, and has published data in Lancet Oncology about 2 years ago about treating patients with BRAF mutant tumors, which we know have very poor prognosis, with FOLFOXIRI bevacizumab. And they had an amazing outcome in progression-free and overall survival in the normally very poor performers. So that I think actually, this could be similar to the strategy we are following in pancreas cancer. FOLFIRINOX is clearly superior to gemcitabine, so aggressive cancers need aggressive therapy. So I can see that this FOLFOXIRI bevacizumab therapy could be used in select patients, even here in the United States, where we don't have that much experience, because also the toxicity profile wasn't that bad. I mean, they had more neutropenia, they had more nausea, vomiting, but and neuropathy, because oxaliplatin was used, but it didn't translate into a higher rate of febrile neutropenia, which is a life-threatening complication. So overall, I think, for select patients, I might even consider using it.
Right. And they had previously shown that FOLFOXIRI without Bev was better than FOLFIRI without Bev.
So they had some iterations in their treatments, and they showed convincingly that response rates, for instance, go up and when you combine all three drugs in this setting compared to just our normal FOLFIRI or FOLFOX setting. And I can envision, we've talked about, response rate as a parameter which we like to shoot for in the liver metastasis conversion therapy setting. And I think, this is a viable treatment option.
So this is something that one could consider for highly selected patients. Patients, number one, that can handle an aggressive FOLFIRINOX type regimen.
Correct.
And who really need a more aggressive approach to a more aggressive disease.
Yep. And again, I could see that this could be used for these BRAF mutant tumors, which we really don't have good standard therapy for. There's a lot of investigational agents out there right now, a single agent or combination to target this patient population with BRAF mutant tumors, But I do believe, this, looking at the tools we have right now available in our clinical practice, I could consider using FOLFOXIRI, FOLFIRINOX plus bevacizumab as one of the tools to treat those patients up front. Yeah.
Very good. And then the David Cunningham study, where we know that oxaliplatin probably doesn't work as well in the elderly population as it does in younger people. But I think it was important to do this phase 3 trial and document that bevacizumab capecitabine was tolerable and was beneficial compared to just capecitabine alone.
I mean, that's a study which we would have very difficult times running in the United States. Actually, just shut down an elderly study which had a similar approach looking at the use of bevacizumab in the elderly patients added to chemotherapy. And this was more or less what David Cunningham showed. They looked at patients over 70, 280 patients, randomized comparison between capecitabine or capecitabine plus bevacizumab. Now you think, elderly patient bevacizumab, there is actually pretty good data that elderly patients, in the absence of the conventional contraindication, can tolerate bevacizumab. This is similar to a trial we've seen published several years ago, the MAX trial, the Australian trial, which looked at a kind of all-comers, younger, older patient population, CAPE versus CAPE-BEV versus CAPE-BEV natomycin, which didn't add anything. And it was reassuring to see that the addition of bevacizumab to capecitabine really improved progression-free survival as the primary endpoint quite significantly from 5.5 to 9.1 months. I mean, that's a strong hazard ratio. 9.1 months progression-free survival first line.
Pretty good.
That's pretty respectable. I mean, that's something we see with FOLFOX-BEV even. And overall survival wasn't bad for the elderly patient population over 20 months. I mean, in this limited group patient. Didn't reach statistical significance because it's a smaller trial, 280 patients. But I think the trend was clearly plus 4 months in overall survival in median, hazard ratio in the range of 0.75. I think this was not a bad strategy. It actually raised the question, really, and you've alluded to that, do we need oxaliplatin? Do we need irinotecan in elderly patient, perhaps in any patient first line, when we have a fluoropyrimidine bevacizumab combination? And it's my strong belief that this is a very synergistic combination between a fluoropyrimidine, CAPE, and bevacizumab. This is what probably drives the whole BEV effect that we see in other trials.
Does it say anything that our best drug for colorectal cancer is 60 years old?
We had a discussion a couple of days ago here at ASCO GI. What's the drug you would take onto an island if you could take one drug to treat colorectal cancer back with you onto an island? It's 5FU. Yeah. In whatever form. And I think since then we've only made incremental benefits and changes.
Well, and the other interesting thing about the Cunningham study, I thought, was the median age was 76, 77. Yep. So that was the median. There had to be people in their 80s as well as everyone had to be over 70.
Absolutely. This is a great set of patients, actually.
Right.
Yeah,
and these are the sort of patients that everybody sees every week in their practice.
Yeah, I actually like this very much for practical purpose. So this is a viable treatment option for our everyday practice, in particular in elderly patients where you might not want to use oxaliplatin because, neuropathy in patients who are elderly, you might be having problems getting around. I think neuropathy might affect elderly patients, vulnerable patients more than younger patients.
Right. Okay. So let's move on and talk about stage 2. And we know from the NCCN guidelines that adjuvant therapy for stage 2 is really only recommended for patients who have high-risk disease, whether that be a T4 lesion, obstruction, or extremely poorly differentiated disease. But the British Columbia group did a very interesting study considering that therapeutic recommendations are fairly rigid in the Canadian provinces. They did an exploratory analysis of all their regional centers and took a look at all the stage 2 patients, whether they got adjuvant therapy or not. So tell us what they found and what they recommended.
So that's a population study. It's not a randomized controlled trial. So you really see what happens to the patient that you're treating And there's, of course, some leeway in whatever you're treating these patients with. Jordan Willing gave a discussion of the data, which were quite interesting. Number one, I think the garden variety stage 2 patient from the British Columbia analysis really didn't benefit from any adjuvant therapy. Now, they didn't specify the adjuvant therapy. And there's some discussion about fluoropyrimidine oxaliplatin. And I actually do believe, based on all the evidence we have from randomized trials and meta-analysis and pooled analysis, I think physicians, if they use oxaliplatin in the stage 2 setting, they're overestimating what they're actually doing. Right. So now it's interesting to see that the low-risk stage 2 patients, the garden variety T2, T3, N0 patients, adequate number of lymph nodes, clearly not the T4 but T3 tumors, they didn't seem to benefit at all. And this is pretty much in line what we've actually seen emerge recently. I think the misconception that stage 2 patients, all stage 2 patients can benefit from chemotherapy came from Quasar. Years ago, quick and simple and reliable study, so-called stage 2 patients were treated in the UK with or without fluoropyrimidines, and there was about a 2.73% survival benefit at 5 years. But at that time, the median number of lymph nodes retrieved was 6 in this study.
Yeah.
So there's probably some contamination from stage 3 tumors, which could have driven the benefit in adjuvant therapy. So the question is really out there, and this is the question that was addressed in the British Columbia analysis. Do stage 2 patients benefit from chemotherapy at all? And there's a big question mark to that. Now, they did find a subgroup of patients, those patients with, let's say, T4 tumors, perhaps with another bad prognostic factor or differentiation or lymphovascular invasion, neural invasion, perineural invasion, etc., perforation, etc., one of those classic clinical factors. Those patients seem to benefit from adjuvant therapy. Now, interestingly, not with relapse-free survival or disease-specific survival, but with overall survival. Right. And how this correlates, I don't know. But to make a long story short, in my clinical practice, I do believe that a T4 tumor, when you look at overall prognosis, is actually worse, a T4 stage 2 cancer, T4B in particular, than, let's say, a stage 3A cancer with let's say, 1 out of 25 lymph nodes positive. So I personally tend to agree with the results in my clinical practice that I would offer adjuvant chemotherapy for a patient with a T4 tumor, in particular if this patient is otherwise healthy, young enough, and doesn't have any comorbidities which would preclude chemotherapy.
Very good. Let's move on and talk about molecular profiling. There are now 2 gene expression profiles on the market, the Oncotype DX for colon cancer and the Coloprint assay. And there was a presentation today, looking at other molecular profiles and trying to break patients down into various molecular groups. And there's been a number of retrospective studies. Sabine Tejpar looked at all the PTAC3 data and trying to determine, if there is a profile that can separate patients not only into better defined prognostic groups, but also into groups that may benefit from specific therapy. What do you feel is the role of genomic profiling at this stage in colorectal cancer?
Yeah. I think it is the future of how we're going to subdivide colorectal cancer. I mean, and you alluded to that, there are various different ways and subcharacterizations and subclassifications of colorectal cancer right now, whether you eventually by gene expression profiling turn into 3 groups or 5 groups or 6 groups. But these are research tools at this point in time. I think we have nothing ready for general use if we talk about, let's say, deep genomic profiling. But I also believe that the future of colorectal cancer therapy, future of clinical trials, etc., is actually really linked to exactly this strategy, that we're not treating all patients alike in the adjuvant and in the palliative setting, but that we're looking more for molecular subcharacterization of tumors. We had the data of the Cancer Genome Atlas network presented in colon cancer and rectal cancers in Nature in 2012. It's published, so we know about deep genome sequencing molecular profiles of colon and rectal cancers. I think we are at the verge of really subclassifying these tumors with potential prognostic clear and predictive implications how to treat these patients differently. Now, when you talk about the available tests that are on the market right now, Oncotype and Coloprint for the adjuvant setting, the problem with these tests is they give you prognostic implications. They do not give you a predictive marker. This patient will benefit from adjuvant therapy, whether it's fluoropyrimidines or oxaliplatin. So it's kind of a relative benefit assessment based on the overall prognosis patients have. And in the end, I mean, there is an interesting presentation actually from our Mayo Clinic Research Consortium looking at how can Oncotype DX as a tool help physicians make decisions on yes or no for adjuvant therapy. There's a substantial number of physicians who had to actually declare what their strategy would be for a stage 2 patient who changed their mind when they got the Oncotype DX result. About 45% of physicians changed their mind about yes or no adjuvant therapy. And there was actually more trend toward no adjuvant therapy than to yes adjuvant therapy when people switch their mind. But I look at this more as more or less educational tool. It is for someone who is in a community setting who is not as familiar, let's say, like a colorectal cancer experts, about overall prognosis and what different parameters really mean for prognosis. Getting a result and a MMR test, for instance, which is embedded in the Oncotype DX analysis, and a readout and a printout, this is the 3-year disease-free survival estimate for these patients. I think this is it's more an educational tool than a helpful tool for someone who's embedded in this field.
So do you think these gene expression profiles add a significant amount of greater information than one could get just using Adjuvant online?
Yeah, so that's the question that I would like to raise, and we have not had kind of a comparison using Adjuvant online versus using Oncotype DX, which I would like to see actually, because Oncotype DX is not cheap, Adjuvant online is free, and it's pretty easy to use, and you have an immediate turnaround. So I personally use Adjuvant online sometimes as a tool to show my patients really and to use it as a printout to really discuss what relative risk reduction and competing risks of dying is in an elderly patient, for instance. So in my personal practice, I do not use Oncotype DX as much as I do use Adjuvant online.
Very good. All right, let's move on to rectal cancer, or move down to rectal cancer.
Down to rectal cancer, yeah.
So this afternoon, the final session of the meeting was really interesting. Probably part of it was interesting because it was moderated by John Marshall, who missed his calling and should have gone into show business.
Yeah, and would have probably made a lot more money.
And would have made a lot more money.
Yeah.
But there were some interesting case presentations and then discussed by a fantastic panel with Deb Schrag and Paulo Hoff and Jose Guillem, and talking about frontline therapy, for locally advanced rectal cancer, or maybe not all that locally advanced. They presented a case of T3N0 and what to do. And there was a real variation of opinions among those who voted. But then Deb Schrag from Dana-Farber got up and talked about the trial that she is leading, the Prospect trial, really taking a look at whether or not everybody needs radiation therapy as far as neoadjuvant management of rectal cancer. And is there a role for neoadjuvant systemic chemotherapy prior to chemoradiation? So tell us a little about that trial. It's an alliance trial, so you all are participating.
Yeah, it's an intergroup trial, because this question really warrants a whole U.S. national endeavor. So the question that was raised in this trial is, can we get away with neoadjuvant chemotherapy alone without radiation therapy for the higher rectal cancer? So not the low-lying rectal cancers, where I do believe at this point in time neoadjuvant radiochemotherapy is still standard of care. It's very difficult to move away from that because we really want to make sure that we're not compromising outcomes for patients, particularly with regard to a local recurrence, because the low-lying rectal cancer, they are surgically very difficult to address. And even if it doesn't lead into, let's say, differences in survival, but the morbidity of a local pelvic recurrence is just horrendous. I mean,
so this is tumors at the lower margin from 5 to 12 centimeters.
Yeah, actually 5 to probably up to 8 centimeters. But anything above that, I think is free game for looking at, what is the role of chemotherapy alone. Now that when we have some data from a memorial where Deb actually came from and started some trials and studies in terms of using a FOLFOX-based neoadjuvant chemotherapy, no radiation therapy. And they had, in the initial set of, let's say, 4 dozen patients, pretty good responses with path-CR rates in the range of 30%, which is at the higher end of what we normally expect with chemoradiation therapy. Now, that's a select group of patients, it's a kind of referral practice and all the, but I think it's intriguing enough to see, as a hypothesis generated finding, whether this can be used in routine practice now instead of chemoradiation therapy, to get radiation therapy out of the equation, which we all know has potential long-term consequences. I mean, we're talking about proctitis, chronic bladder infections, bladder irritations, kind of sexual dysfunction, we shouldn't underestimate those. So the long-term complications from radiation therapy are not trivial. So if we could get away with just chemotherapy up front and then leading patients to surgery, etc., I think this would be great. Now, the trial is very carefully constructed. It's actually a complicated trial in its design. There are a lot of safeguards in there because you don't want to compromise outcomes for patients. Right. It has an initial phase 2 component right now to see, is this actually feasible? Are patients and physicians willing to do this? Is this a very clear assessment of, is this potentially inferior for the early outcome, meaning local recurrence, etc.? And physicians actually have to be credentialed to do the appropriate surgery. So there's a lot of safeguards in place not to harm patients by deviating from what we call standard of care. But I believe this is one of those trials, if successfully conducted, could potentially change the standard of care worldwide, clearly for the benefit of patients.
It'll be very interesting.
Yeah,
there was also an abstract presented from Brown University, a small group, less than 40 patients, where they treated everyone with FOLFOX up front, and then all but I think 4 of the patients went on and got chemoradiation, followed by low anterior resection, and then eventually closure of their temporary ostomy. But they also found about 30% pathological CR, which is the goal.
Which is the goal, and I think this is, again, at the high end of what we normally see. Now, I think this moving more toward moving more chemotherapy in the neoadjuvant setting can make sense also when you talk about the actual kind of what patients die of. It's not the local tumor, but this metastasis. So the idea of treating micrometastatic disease as early as possible, including and then devitalizing the tumor, before you do surgery, can actually really make a difference. So not only in terms of local control, but also perhaps even overall survival.
Very good. Well, there were a tremendous number of abstracts submitted this year. I think they said 674 or something like that. And because there is only one concurrent session, there's only so many that can be presented orally. But there were an awful lot that were just posted on the bulletin boards. Were there any that struck you as you went down those aisles that were particularly interesting and maybe, if there had been more oral sessions, might have made it to an oral presentation?
It's probably the shortcoming of this meeting, which has a lot of educational focus, rightfully so. That's why people come here. But the abstracts are kind of dispersed in between and have very limited oral presentations. But what I actually like to see, and what people have been waiting, what I like in these posters, what people have been waiting for is the question of head-to-head comparison in first-line, second-line palliative management of metastatic colorectal cancer between an EGF receptor antibody and bevacizumab, KRAS wild-type tumors. I mean, we have a large trial which we're dying to get results on, the 8405 intergroup trial, CLGB leading this endeavor. about 2,000 patients randomized to chemotherapy plus bevacizumab or chemotherapy plus cetuximab in KRAS wild-type tumors. We'll not see data at ASCO. Efficacy data is probably, fortunately, survival events come in late, which is good for our patients. We'll probably see something at ASCO 2014. But we have there are two phase 2 trials, decently sized, 250 and 140 patients in first line and in second line, comparing chemotherapy Bev versus chemotherapy plus panitumumab in KRAS wild-type tumors. And interestingly, the question is, what could we expect from getting head-to-head between two biologic agents here in a KRAS wild-type patient population? And the outcomes were more or less a wash in terms of progression-free survival, overall survival as much as was available, and response rate. Perhaps the second-line trial, a little bit more responses for the panitumumab arm in the patients compared to bevacizumab. But second-line response rate is not that relevant compared to, let's say, first-line, where you might move patients into conversion of metastasis setting. So in the end, it was pretty much, you look at the data and say, yeah, both options are on the table and both options can be used. So this ties into the recent approval of cetuximab for KRAS wild-type patients with tumors in conjunction with FOLFIRI here in the United States, something that has happened in Europe for several years ago. So we have now a cetuximab treatment option, even FDA approved, in first-line therapy for patients with metastatic colorectal cancer, KRAS wild-type tumors. In select situations, I think it's a viable option. And the data presented for the other EGF receptor antibody, panitumumab, versus bevacizumab really say, there's not a lot of difference. Now, side effect profile, rash versus no rash, hypertension versus no hypertension, might sway people one way or the other, but you really can't say, it's a mistake to do this or that in KRAS wild-type tumors.
Well, KRAS mutation is generally considered to be a fairly early event in the development. Is there any evidence that you can go from KRAS wild-type to KRAS mutant after multiple lines of treatment?
Oh, yes. This is actually an interesting topic. There's emerging evidence right now that there is a population of patients that really goes from KRAS wild-type to KRAS mutant over time. We actually did analysis in our correct regorafenib study where we used the so-called beaming technology, amplifying circulating tumor DNA, and correlating the mutation status of KRAS mutation status that we had with the primary tumor that was resected several years ago, sometimes in the correct study, which was a last-line study. And we found about 10% more KRAS mutations in patients with KRAS than we expected. So there is about 10% of patients with KRAS wild-type tumors initially who eventually converted into KRAS mutation. And there are two papers in summer of 2012, one from the Vogelstein group at Johns Hopkins and one from the Italian group, that documented exactly that. And there are two theories right now. Is it a new de novo mutation that occurs on treatment, or is it a clonal selection that happens, that these KRAS mutant clones already exist and they only get a survival advantage and grow out when you have a KRAS target, an EGF receptor targeted therapy. And I don't think we know exactly which theory is right now, but there is clear, along the lines of what you just asked me, there is a certain subset of patients, perhaps 10%, perhaps more, that develops KRAS mutant tumors when they were started out as KRAS wild-type. Now the question is, it could be different from metastasis to metastasis.
Right.
It could be, this ties into the emerging tumor heterogeneity that we appreciating more and more, and we have seen data from other tumors like renal cancer, whatever, that metastasis in one body, different metastasis sites, can have different genetic alterations.
So was there any evidence that those patients who had previously been exposed to cetuximab or panitumumab had a greater tendency to develop KRAS mutations?
A good question. In the study that we ran, in the regorafenib study, all patients had EGF receptor therapy.
Everybody had it.
So it's very difficult to really have a causal relationship. In the models, in the animal models, there was the idea of more, at least in the Vogelstein model, of clonal selection. So there was some kind of a selection pressure from the EGF receptor antibody. And if I had to, I think it makes sense that there might be some heterogeneity in terms of KRAS status in one tumor, and that over time this clone just gains the benefit of being resistant.
What kind of begs the question of whether or not you should use your anti-EGFR agent early as opposed to waiting, because maybe a mutation will occur and it'll no longer be helpful.
A great question. We've routinely seen that hazard ratios when you use EGF receptor antibodies, when you talk about comparison, EGF receptor antibody versus no antibody, are better in terms of clinical benefit in a later line setting than in an earlier line setting. Is this one of the reasons why do you see that you should limit it to a later line? I think we need more data on that. But it's intriguing. It shows us, 10 years ago, we would not have talked about this. 10 years ago, when first ASCO GI, there was no KRAS. We didn't waste any thought on molecular profiling of these patients.
Yeah.
And nowadays, that's the buzzword.
Yeah.
That is the buzzword.
In everything.
Everything.
In everything. Well, Axel, thank you very much. It's always really interesting. I always appreciate getting your perspective on the data. Clears up a lot of my confusion. Not all of it, but a lot of it.
And my confusion.
So I appreciate it. And thanks to all of you for watching this final segment of Best of the Day from the 2013 ASCO Gastrointestinal Cancer Symposium. I hope you will look at all the other interviews from this year's meeting. There's a lot to learn. Thanks so much. Bye-bye.